Hello. Hello, friends. Mr. Midwife says he'll be late, but he's here in spirit. I love it. Love it. Um, Hi. If we haven't met, I'm Bree. I'm an RN mentor, interview strategist, content creator. And I like to go live once a week just so we can talk in real time. I do include usually a topic so that it doesn't get boring or weird. So this week we were talking about calcium channel blocker overdoses, which are super fun. So you're going to want to watch this one. Feel free to jump in at any moment and add questions, comments, opinions, veer off topic. I'm pretty much an open book. A little ADD, but I'll eventually come back to the topic. So I know Pink, right? Scott's here. What? So today will be a fun one, very like education heavy, but so I have done a blog on this and I have done a TikTok on this. And the TikTok that I made was the most viewed TikTok I've ever had. And it's clear to see why, because it's one of these like drama factor type of patients. It's just, they're shocking. They're absolutely shocking. They're rare, but if you ever have the opportunity to take care of them, they will live in your memory, your traumatized memory forever, because they defy logic. They defy everything that we know to be true about medicine and how patients look when they're sick. And it's just weird. It's just weird. And there's some very outside the box kind of treatment regimens that can truly save their life, but require a lot of work. So these patients typically, okay, so we're going to get into it in depth, but they're in massive cardioplegic, like cardiogenic and vasoplegic distributive shock, both. And so because of that, pressors are like just dropping a little bit of water on a bonfire. It does nothing. It doesn't work very well, but high dose insulin can turn the tides. And you're talking like, for a small person, like 700 units per hour of IV insulin, which is a little butt puckering for those of us who work at the bedside. That's scary as crap. So we'll get into it in just a minute. I feel like that was like a commercial intro. And a note from our sponsors. Except there are no sponsors. Yes. Hey, Clayton. Glad that you're here. Yeah, Pink. So we have to take a minute and talk about the Pink because, you know, this is my show. And we can't all be just talking about medicine all the time. It's got to be some kind of fun stuff. So this is I do this while I'm getting ready for my night shift to save on time. And there's a little bit of, you know, aesthetic stuff on here, which is fascinating to me that the majority of my contributors here are men because it's always about makeup and pretty things. Hi, Alex. Oh, Alex says, I sincerely look forward to these videos. Oh, I'm so glad. I'm so glad. Educational stuff isn't always fun to watch. So it's, I don't know. I just like it when people are interested in it because it's a totally different audience. I get it. Your brain doesn't want to do too much heavy thinking all the time. You just want to be entertained. So try and make it fun. So I wear bright pink. That is actually my color for the season. I'm pretty sure is neon pink. This is a little bit more bubblegummy, but like, I wish I had my shoes to show you. I bought shoes. They're this color and they're phenomenal. They're by a company called No Bull, which I see nurses wearing around the hospital. And I think they're so pretty. And I never did buy any because I don't like to buy things online. It never fits. But I bit the bullet and bought them, and they are everything. They're just everything. Neon pink. And the phone case. I'm so extra. I mean, you know. So are y'all having fabulous weather where y'all are like we are? Georgia has been nuts for us this winter. It's been nothing but rain and freezing cold. In fact, we had such a harsh winter. We had was it February? We had like a really bad frost. It got down to like 8 degrees, which never gets single digits in Georgia ever. My azaleas all died and now they're not coming back. And I'm so incredibly, incredibly sad about that because they were gorgeous knockout azaleas. Encore azaleas. So they bloom multiple times a year and they're beautiful and they're dead. So mad that I didn't think to cover them up. It's very tragic now that it's spring. Okay, so I'm just laying out all my tools here while we chit chat. Okay. All right. let the moisturizer set in, and we'll get to some medical stuff. Scott said, so Scott lives in San Francisco. It's never bad weather there. So, I mean, you have nothing to contribute to this conversation, Scott. It's always perfect there. We know, we get it. But you got to climb all those hills. Clayton said the weather is amazing here in Dallas. I didn't realize you were in Dallas. Does it get hot there? I forget. Is that like in the middle of the state? Like, it can be a mess. All right, fine. Sorry, I've got crap everywhere. I don't have enough like counter space for all the like equipment and things that need to be up here, and it's just like precariously balanced everywhere. Okay, let me start talking medicine because this one's kind of heavy. This is a heavy one, y'all. But these people are super rare, but when you get them, it is so scary and you don't know what to do that it's really helpful to have some references in place, because when you get it, you can truly be the hero of your entire hospital, because nobody, sometimes even the pharmacists have no idea what to do for them. So you can truly swoop in and save the day with these people. Clayton said, hell yes, it gets hot as in North Texas. Yeah, I believe it. Sweaty weather. It's going to be like that this summer too, I'm pretty sure. For us here, sorry, let me just load my notes here. So the first thing is the type of people that I've seen with this, I've taken care of four people in my career, 2 of them within the last couple of years. So they're the ones that stick out in my mind. And the ones that I have seen are people who accidentally took too much of their calcium channel blocker. And they come in different classes, but the last one I had was amlodipine. What in the world? She was a sweet little grandma. No, that was not the last. That was the second to last one that I had. And this was the only one of the 4 who ended up dying. But she confused her amlodipine with Kayexalate, which had an order on it to dissolve it in water and drink it. So she took her entire bottle of amlodipine and dissolved it in water and drank it. So I've never encountered anybody who intentionally took too much. I don't know. I'm sure there are people who do, but I feel like people who overdose on a whole bottle of a calcium channel blocker are probably overdosing on everything in their cabinet. So who knows what you're going to get? You're going to get a whole mix of various things. But the ones that I've seen have all been in isolation, just this. So it's totally crazy. So anyways, okay. So the problem with it, the reason these people are so incredibly sick, we have to talk about the pharmacodynamics of what calcium channel blockers do in order to understand why it's so bad. So bear with me. This gets a little heavy. Please raise your hand for questions because I don't want to say anything wrong, but I always do. Clarify. All right. So this is how I started the blog. And this is, I think, in essence, the best way to think about it. Calcium channel blockers are the opposite of pressors. Like beta blockers are, magnesium is nature's beta blocker, right? It helps with slow everything down, chill it out, everything just ramps down. So calcium channel blockers are like this, except worse. So they have multiple effects. So first, negative chronotropy and dromotropy. So that is your rate and the AV nodal conduction. So not only is it going to slow down how fast the heart is beating, it's going to slow down how fast the heart is getting the electrical impulse to beat. So it's a twofold effect there. And it hits at it reduces the action potential and slows the conduction through the AV node, but also does that at the SA node. So you have multiple phases in which the heart goes, okay, we're doing too much. Let's just slow everything down. So as an effect, you get a reduced heart rate. Imagine if you take a whole bottle of that, you ain't gonna have no heart rate. There's no impulse and no rate, no heartbeat. The other thing it does in regards to rate is that it suppresses firing of aberrant pacemaker sites. So atrial impulses, all of those are kind of shut down. So people who struggle with like wandering pacemakers or who have AFib, they will often be on calcium channel blockers because it has this effect of like telling those like rogue sites to stop telling the heart to beat. So there's a like side effect of this. All of this compounds, right, to reduce heart rate and arrhythmia. The second effect is negative inotropy, which is your contractility. So not only is it going to slow the firing and the rate, it's going to slow the pump of the heart. So it's not going to squeeze as well. It does this by binding to the cardiac cells or myocytes, which reduces how much calcium influx goes into the cells. And calcium is what makes those cardiac muscles squeeze. So if you've taken something to block this receptor so that calcium cannot get into the cell and make the muscle move, the muscle's not going to move. So you're not going to get pump. Hey, Mr. Midwife, you know what? As Scott said, did you bring your note late to class? It's the only excuse required. And you're only 10 minutes late. I was expecting you to be like, you know, these things have gotten longer and longer. So you could be 30 minutes late and still catch the whole thing. We were just talking about the weather anyways. Okay, and then the other thing that impacts negative inotropy is that in higher doses of calcium channel blockers, you induce a reduced cardiac and cardiac output and cardiac index. So you'll have lower blood pressure because the heart's not pumping as well. So in summary, the first two effects that we're seeing from calcium channel blockers is negative chromotropy, negative dromotropy, negative inotropy. Your heart rate's going to reduce, your blood pressure is going to reduce, all because the heart itself is not doing what it needs to be doing when you get too much of it. I mean, a little bit of it is good, right? We need that in some people. That's why we give it to people. But the kicker, okay, so it's done all of these things, but the kicker of this is not only does it affect the heart, it also affects the pipes. So by pipes, what I mean, okay, when I talk about pressors and the receptors they bind to, I always talk in terms of pumps and pipes because that's what makes sense in my brain. So pump being the heart and the squeeze, how much blood you're getting out into the body, into the tissue, and the pipes, meaning depending on what the pipes are doing, that heart can be pumping just fine, but nothing's getting out there. So that is talking about afterload or SVR, systemic vascular resistance. All of those kind of mean they're saying similar terms, you just interchange. Oh my God, you guys kill me. Sorry, sidetracked here by Mr. Midwife, who is apologizing profusely for being late. Okay. What was I saying? Okay, so the pipes. The pipes. This is what will make your blood pressure drop. When the pipes are either, when they're vasodilated out, they're really, really dilated out, and your SVR, your systemic vascular resistance, is low. Or if your third spacing in those vessels are leaky, like in sepsis. Anytime that fluid in the blood vessels is leaking out into the tissue, it isn't where it's supposed to be. So you're not going to get good blood flow to the tissue. It's all sitting out in it instead of getting to it. So calcium channel blockers reduce your SVR because it dilates those pipes. So not only do you not get rate, do you not get pump, you also dilate things out. So it's like barely moving this little trickle of blood, and it's just floating in space. It's not getting where it needs to go. So you have a double whammy effect that is ramping everything down. It is the exact opposite of Levophed. Too much calcium channel blocker, actually not even too much, just calcium channel blocker. Calcium channel blocker is the opposite of Levophed, total opposites. Levo, kind of in a more balanced way, hits the pump and the pipes. This one hits the pump and the pipes in the opposite way. That's the easiest way to think about this, y'all. Scott said, so is it me or yes? Are calcium channel blockers like DIG? Yes, yes. And you'll see people who are DIG toxic. I personally have never had anybody who's overdosed on DIG. I'm sure it happens, but yes, you will have similar effects. Okay. The fourth thing that is weird, okay, this is weird, and we'll come back to why this is relevant in this story in a little bit, but the fourth pharmacodynamic effect of calcium channel blockers is that they relax the vascular smooth muscle in the pancreas. Okay, this is weird. Bear with me. The reason this matters is that you're going to block calcium influx into that muscle, which means that muscle's not going to work well. So then the pancreas is not going to work well. So then you're going to get a net effect of insulin resistance, which means they're going to be hyperglycemic, which is God's way of protecting these people. I'll tell you why in a minute. But person who takes too much calcium channel blocker will have a high blood sugar. I don't see this effect in people who are taking therapeutic doses. Anecdotally, I haven't really done the research, but I haven't seen it anecdotally. So I don't think this affects people with just normal doses. But in high doses, their sugars will rise because the pancreas isn't working. We'll come back to why that's important. So then, let me pause for a minute and put on a little bit of makeup. Because yeah, we're 50. Oh, I'm on good time today, y'all. I'm on good behavior. It's because, so tonight is my first night. I didn't work last night. Usually when I'm doing these on a Thursday, I work the night before and I'm like, my brain is firing slow. My body's moving slow. Everything is just exhausted from the night before. But that's not the case. I'm working a little later this week. So tonight and tomorrow night, which I hate doing because that means I'm going to be sleeping during the day on a Saturday. And guess who all's home on Saturdays? I'm such a light sleeper, even when I'm exhausted. Yes, Alex, we're going to get to that. That is the crux of this. But we're going to give insulin, and it's going to be for not mostly for the sugar, but it will hit that, which is protective. Y'all, I just bought, I got to tell you this because I tell y'all everything. I'm going with my bestie and one of her friends to see Moulin Rouge, which is coming to the Fox next week. We've had tickets for a while. And my friend is one of these like super fun friends. And she's like, okay, we're all dressing up. I'm not a dress upper. It's too stressful for me finding the right kind of costume, whatever. We're dressing up. So I just ordered an outfit on Amazon. Let's pray that it works out and fits because nothing ever fits I order from Amazon. But I bought an outfit, dressing up like we're flappers. Although I'm kind of, anyways. I'm excited. I've never seen the show. I've seen the movie, never seen the show. What's next? Got to get the foundation going. My rosacea is looking a lot better. I know y'all are thrilled about that. I know it was weighing on your minds heavily. But this regimen that the new dermatologist has me on is doing it. I'm super happy. Made this dang girl very happy with life again. Great show. You've seen it, Scott, I'm sure. I'm definitely a theater girl. I think people who can act and sing and dance, like that triple threat to me is just, I'm just like in awe of it because it's so much. It's so much. Like how do you get so much talent? It's not just one genre of skill. It's all of them combined at one time. And the Fox is a pretty good venue here. We go probably, I don't know, 3-4 times a year to various shows because I love it. But yeah, I'm looking forward to it. I don't have a lot of shows actually on the docket this year because I took my daughters and we went to New York in the fall and we saw a couple shows while we were there. So a lot of what's touring right now is stuff I've already seen. Not that, I mean, I've seen, Wicked's my favorite. I've seen it 3 times. Just after a while, it's kind of like, good to see something new. 3 skills, fearlessness, exactly. Fearlessness for sure. I think those kind of people, they just got it though. Like they're not really even afraid. That's just that's their gift. So it's natural to them. Although I don't know, maybe they do. My daughter dances and she says she gets nervous every time she goes on stage. I'm like, why? You make it look so effortless. Her show was great. By the way, I know y'all, those of you who were here last week met her. We had her show week. They run 3 nights of shows and I had to miss the first night, but oh my gosh, it was so good. It was one of the best ones ever. They dedicated it to a girl in the school who died this year. And y'all, oh my gosh, I cried my eyes out. It's just beautiful. Phantom of the Opera was an amazing. Okay, I've seen Phantom, and I'll be honest, I did not love it. It's okay. I mean, I feel like it's one of those shows that's like people love it because it's just so like quintessentially classic, like old show, right? I will say, I don't know, the music is good and it's powerful in its own way. It's just kind of like, I don't know, it's a downer show. I like shows that cover, all the emotions, make me laugh, make me cry. But the set, holy crap, the set of Phantom when the staircase and the chandelier when it comes down is, I mean, I have a great appreciation for it. It's kind of Les Mis. Okay, Les Mis is another like tragically sad one that I have never watched because, well, I've watched like the TV version of it, but like I don't know that I would pay money to go see it because it's so depressing. Like Little Shop of Horrors. I want to go see that. So a little teeny tiny local theater from my college town puts one on every year that I've heard is great and I've never seen it. So I'm going to go see that this year. I'm glad you reminded me of that. I'm going to go see that for sure. Fun one. And then Wicked and what is DEH? Oh, and I don't know what Come From Away is. I don't know what either of those are. You're going to have to teach me. I don't know. There's a Michael Jackson one and a Tina Turner one. Both those look great. Okay, sorry. Let me get through this little section and we can get back to what y'all came here for, which is the fun of calcium channel blockers. So in the blog, I talked about, the kind of people who are normally on calcium channel blockers. So heart failure, hypertension. Let me pull out my notes. Hold on, please. The therapeutic indications, not the taking too much. Oh yes, vasospasm. I forgot to talk about that. So off-label. Well, I don't know if it's off-label because it is labeled. But if you've ever had a patient with a subarach hemorrhage and they have vasospasm, they are on like nimodipine to prevent the vasospasming. And also coronary vasospasm as well. So people with angina are often on calcium channel blockers just for the angina. Pulmonary hypertension, SVTs, hypertrophic cardiomyopathy, and there's some off-label uses too. So then we get into the hard stuff, y'all. I'm sorry. There's just no easy way around it. There are two main chemical classes of calcium channel blockers, and it matters. It matters because they have, just like in the video where I talked about pressors, where pressors have they all have some effect on different receptors, and some of them affect all the receptors just in different affinities. Like I talked about levo being kind of the most balanced of the pressors because it hits the pipes and the pump, and that's really those receptor sites. Calcium channel blockers are the same. They come in different classes, and the different classes kind of hit different receptors a little bit more one than the other. So based on the drug that they overdosed on, you may see more effects of this clinically than that effect clinically. So you need to know what it is they took. Yes, Scott hit the nail on the head, and I don't say these names well, but I will try. You have dihydropyridines and non-dihydropyridines, and non-dihydropyridines have two like subclasses. So what I mostly have seen is the dihydropyridines. Dihydropyridines are your dipene drugs: nifedipine, amlodipine, nicardipine, nifedipine, amlodipine, nicardipine, nimodipine. Yes, all the dipenes. Your last exam, which you rocked, I'm sure. Why didn't I do this video a month ago when you had your test? I should have known. Okay, those classes, the dipenes, they have more of the vasodilator or pipe effect than they do on the heart. Less of the pacemaker, less of the chronotropy, dromotropy, although it still has it. It's just that it has more of the effect of the vasodilation. So you're going to have issues with hypotension, but the heart rate may be maintained because you don't have all that AVSA node blockage, direct slowing of the heart rate. You have more of the vasodilation. So you might not have as much bradyarrhythmias. These class of drugs are more often used to treat hypertension. So these are the ones I've seen in practice because this is what you see people taking in the real world. Sorry, my phone's going off. Symptoms that you will see, well, not symptoms, side effects of the drug: lightheadedness, flushing, headaches, and peripheral edema. So obviously, if they overdose, you're going to see way more of this. Because there is more predominance toward the vasodilator effect, than there is of the heart. What you may see is a reflex tachycardia. Yes, tachycardia. So because the body's like everything's vasodilated out, the tissues are getting less blood flow. You have that baroreceptor reflex, which says, we're stretched out too much. We don't have enough blood volume. Let's speed up our heart rate, because what is cardiac output? It is heart rate is contractility times heart rate times stroke volume. So what do you increase? Your heart rate. At very high doses, and this is typically what we will see in the really bad overdoses, super high doses, the effects of these two receptor site issues kind of equilibrate out a little bit. So this is the case where you may see someone with an nimodipine overdose that still has bradycardia associated with it, but just less so than the other class. Okay, I think I beat that a horse to death here. The non-dihydropyridines. All right, these are the ones I can't say. Two different types. One class is called, all right, bear with me, phenylalkylamines. Phenylalkylamines. Verapamil. And benzothiazepines, diltiazem. Verapamil, diltiazem. Never seen either of them overdosed. These are more cardioselective. So you're going to have more of the cardiac suppression. You're going to have worsened cardiac output. You're going to have more nodal blocking, so more bradycardia. You're going to have more hypotension. Now, the reason that people who have heart failure with a reduced EF, the reason we don't automatically default to putting them on a diltiazem drip is because of this effect. I'm going to pause for dramatic effect. Because, when there are things throughout your career that you've been doing this for a million years that you do more research on, you're like, oh, damn. Okay, now I understand why clinically this is what I'm seeing, because this is what it does. I just love these like light bulb moments, right? So in practice, what we tend to see is that someone's in AFib RVR, somebody defaults to putting them on a diltiazem drip. And if they're vasodilated out or they have a reduced EF, their blood pressure plummets. And this is why. That sick heart that has a reduced EF does not need any reduction in flow to the coronaries, because it's just going to worsen things. So this is why you don't want to default to giving someone who has a reduced EF diltiazem for rate control. Do you love that? Do you love that little nugget? Okay, so anyways, side note. So I already said that reduced heart rate. Diltiazem, which is the benzothiazepine class, does maintain some of the vascular effect. So you will get some vasodilation with this one. So again, this is why you get more of the hypotension, blah, blah, blah. I already said that. And interestingly, constipation is a side effect. Okay, so in the toxic patient, okay, toxicity sets in at about 2 to 3 hours after ingestion. So if you catch it early, you could give them charcoal and bind. I'm trying to think if I've seen it in real life, if we've had anybody that's been called early. I don't know. Maybe in my ER days when I didn't know what I was looking at. But you could, if you catch it early enough, try and bind it up before it gets out into the tissues. Symptoms of a patient who's toxic on calcium channel blockers: dizziness, fatigue, lightheaded, coma, but interestingly, way less than what you would see with a beta blocker overdose. And in fact, every patient I've ever seen with a calcium channel blocker overdose has not had the coma effect at all. They've had the opposite. They are wide awake and talking to you on massive doses of shock. Like all 4 pressors in all the land, and you still got a systolic of 50, and they're like, can I have the remote? And you're like, what? Like, it's weird. This is what I'm talking about. It defies logic. Somebody in that much shock is usually in extremis. They are dying, and you're like, oh my God. No, these people look perfectly fine, but they're not. It's weird. That's why you remember them. But in beta blocker overdose, you'll have way more of the lethargy and coma effect. I've never seen a beta blocker overdose. Clinical signs are going to be sinus bradycardia, AV blocks, bundle branch blocks, QT prolongation because of that slowed conduction, refractory cardiac and distributive shock. Refractory, none of those pressors are going to do anything or not much, you know, and ARDS. ARDS, why? Why will you see ARDS in these people? Don't you love how I get all excited about these little things? I just love it when things come full circle. It's not what you think. It's not what you think. Did I already do, what have I done? What have I not done? No, did I do that already? I don't think I did. Got a powder or else, you know, nothing will set. And then all this hard work that we're doing here will be for naught. It'll just like wipe right off later on. So we got to make sure we take care of this part of things. And I think I also didn't, I did. I'm getting ahead of myself here. Okay, ARDS. Nobody has an answer. You fail. You all fail today. I'm telling you. So they have ARDS because we are giving them massive doses of volume with the pressors and with the insulin, which we're going to talk about in a minute. So they're going to get tons and tons and tons of volume overload. And often because these people carry a cardiac diagnosis with a reduced EF, they just can't handle it. So you're going to get pulmonary edema. And then because you have shock on top of it, they get into this state of poor compliance and ARDS, and they'll get hypoxic. So the one person who I saw died because of that effect. She had a terrible, terrible EF already. I don't remember what it was. I really wish I did, but I don't. And she was older, so she couldn't handle all the volume that we gave her, even with everything concentrated as much as possible. Couldn't do it. So that's something you have to be aware of in all of this, is that ultimately these people die. I mean, they truly do. If you don't put them on this regimen that I'm about to tell you about, they will die, depending on how much they took and how sick they were coming into it. There's some caveats, but they do. They die. What colors? I'm feeling like if I'm wearing a bright pink shirt, I should probably tone it down on the eyes, don't you think? I think so. All right, we won't do pink eyes today. We'll skip that. I know y'all are relieved to hear that. Colors here. Bear with me for a second here. I'll get this thing set up. All right. 32 minutes. I'm doing great. Charcoal is the first thing you're going to do if you have time. Second thing you're going to do, and people talk about this a lot, and you can give calcium. Okay, calcium is what makes the heart pump. They're not getting enough calcium. You can give them calcium. But here's my whole thing on that. If you've taken something to block receptors, you're not going to, depending on how much of that you took and how many receptors your body has, what's the point of giving calcium? It's not going to get into that blocked receptor. So you can give it, but it's going to be very subpar. Like you're going to have a suboptimal response to it. But you can give it if you want to give it. You can, and you probably should. Go ahead and give them some calcium. There'll be some that are unblocked. You're just not going to get much effect from it like you'd expect. Okay, so then the next step is pressors, and you're going to start adding one pressor, and then the second pressor, and then the third pressor, and then the fourth. You're going to add all the pressors and all the lambs. You're going to start with your most balanced pressor. So if you are on, and I'm just thinking of this now, just, spitting here, but so you can choose the pressor that's right for the problem that you're having. So if you have more of a balanced effect, like you have high doses of the dihydropyridine where everything's equilibrating out, pick a balanced pressor like Levo. But because Levo has a little bit more predominance on the pipes than it does on the pump, it'd be great for this. Versus your non-dihydropyridines, which has more effect on the pump than the pipes, then give Epi, which has more effect on the pump than the pipes. So you could try and tweak it and match it a little better, but ultimately it's not going to matter because you're going to add the second one on very quickly, depending on how much they took. So just add those two. Your next step is going to be some Neo, then probably some Vaso. You might consider Ang2. You might consider methylene blue. you're going to max all of these suckers out, and then you're still going to have no blood pressure, and they're going to be asking for the remote, and you're like, what do I do now? This is where you are going to enter in high dose insulin therapy, and it is magic, my friends. Let me get back down to that section. Okay, so I got to go through all the bullet points of why this works. Methylene blue raises blood pressure, and it does that. I don't know how it does that. I'm sure I knew at one point in time, but I don't know. It's rare that we use it anymore. It's expensive, and it is truly a dumpster fire, last ditch. Like, let's just throw methylene blue on there and see if it works. And it does. It makes the numbers look better, but it doesn't really change outcomes. So we don't use it so much. Pink eye beats black eye, I think. Okay. So the insulin. Why insulin? Because insulin is a direct positive inotrope. I did not know this. And I don't think we don't use it for anything else. So I did a bunch of research trying to figure out if you could use it in a setting where someone else had refractory shock. And I've never seen it indicated or even talked about. So I don't know why. In part because probably it's so much insulin and so much manual labor that it wouldn't be sustainable for everybody who's in refractory shock. And if you can't fix what's the underlying shock, then what's the point of putting this on, because I'll run you through how bad it is. But that is the reason why it works. It's a direct positive inotrope. So you're talking like 1 to 10 units per kg per hour of an IV infusion. So let's put that in perspective. For a 150-pound male, that's going to be what, 75 kilos, 70 kilos, something like that. That's going to be between 70 and 700 units of insulin per hour. And that's for a 150-pound person. We don't have a ton of patients that are that size here in the South. So, I mean, it can be over 1,000 an hour, 1,000 units. And you'll like quadruple concentrate this down, but that's still going to give you like 250 an hour just in insulin. So huge amounts of volume and insulin. Right? So you're infusing this constantly into their bloodstream. So let's think about this practically, right? People are paranoid because insulin kills people. Insulin kills people. Did y'all see? I just watched The Good Nurse. Have y'all seen The Good Nurse on Netflix about an ICU nurse who randomly killed patients? Something is wrong with this dude, clearly, but he would randomly select bags of saline in the supply room and inject them with either fatal doses of insulin or DIG or potassium. And so then you'd go into the storeroom, grab your bag of saline, hang it on your patient, and over the next 12 hours, your patient would slowly decline and they'd die. This is why insulin kills people, and too much. And we underestimate it because everybody in the world gets insulin, but insulin kills people. So high doses of insulin is scary because people die. And so when you're giving that much insulin, you've got to have them on a dextrose infusion. So you've got to counteract all the insulin, reducing your blood glucose. But this is where it gets interesting. Go back to the original physiology where I said that calcium channel blockers in higher doses affect the pancreas, and therefore you have insulin resistance, and therefore your sugars tend to be higher. So you're not on, it's usually, I think it's usually D10. We usually do D10 because you can get more concentrated and so less volume, because everything is going to be volume. You want to reduce as much volume as possible on these people because, again, you're flooding them. But if you can do D5 peripherally and D10 centrally, it's not D50. And I don't know how much. I think you can do D20. I think you can do D20 through a central line. So it might be that, actually. Whatever is the most concentrated is what you can get. D50, you can't concentrate down enough, I don't believe. So anyway, so you're going to hang dextrose to counteract the insulin. But you're not going to need, like if you're giving 700 units of insulin, you're not having to give boatloads of dextrose because they're already kind of hyperglycemic. So it's sort of a protective thing. The body's like, you know what? We know what the problem is. And here's how we're going to address it. I think I'm going to, what color am I going to do here? I think I'm just going to do like this. Do like this right here. So So you have someone on this high dose insulin, you're giving them sugar constantly. So everybody's freaked out about what the sugar level is. So in the organizations where I've seen it done, this is a 2-to-1. This is actually like a 3-to-1 patient. You have a tech or somebody who is allowed, because these days they don't allow anybody to do it, to check sugars, and they are checking sugars every 15 minutes. And that is their whole job, is to check the sugar every 15 minutes. Then you have a nurse who is titrating the drips, because you are constantly titrating the drips on these people. Plus or minus someone to take care of the patient who needs the remote. And you're like, what the hell? This patient is dying and they want the remote. Again, weird. So you've got all these people managing the sugar and the insulin. All right. Okay, the other thing with giving high doses of insulin, Scott said, I think we might have done an amp of D50 with the insulin. Yes. So in practice, where you're going to see this typically is people who have hyperkalemia. And that's my next point I was going to get to, is that insulin is a carrier. Insulin is the carrier needed to get potassium into the cells. So when you give insulin, you shift potassium into the cell. So people who are ESRD, you miss dialysis, or people who have a bad AKI or post-obstructive renal failure, and you use your potassium super high and you get it down quickly, you're going to give shifting cocktail. That's what we call it, a shifting cocktail. And it's insulin, D50, bicarb, sometimes calcium, and maybe albuterol, possibly some K-oxalate, Lokelma, something like that. But it's a whole regimen of stuff to drive down that potassium. So if you're giving 700 units of insulin per hour, what's going to happen to your potassium? So you're giving a lot of potassium. But you have to be careful with this, okay? Because when the potassium shifts into the cell, it doesn't disappear from the body. The total body potassium level is the same. It's just hiding out in the cells. So as things get better and the insulin rate drops, the potassium is going to shift out of the cell, and then you're going to have hyperkalemia. So you're checking labs on these people constantly, like every couple of hours at a minimum. Would treatment of a calcium channel blocker overdose be different for a diabetic? No, I think the treatment would be the same. You just may have more, difficulties with your sugar levels. Like how is that affecting things? Because these people are probably eating because they're awake, asking for the remote. So they're eating and their sugars are already high. You may not need quite as much of the dextrose, but you're still going to need some because of that primary effect of the calcium channel blocker. Because the primary effect of the calcium channel blocker overdose, because of the insulin. Sorry, y'all, I'm getting so confused. It gets confusing. Potassium. Okay, we talked about that. Okay, so where are you going to start? People always ask this. I always ask this when I'm in practice too. Like, okay, so we're on all the pressors. We've already given calcium. They couldn't get any charcoal, nothing to bind it. We're stuck with where we're at. We have massive shock. Now we're going to add the high-dose insulin therapy. And the purpose of this is to replace the pressors. So the focus needs to be on titrating the insulin and getting off the pressors, because the insulin treats the problem. So as you, what am I trying to say here? You have to pick where to start the insulin dose. And I said it could be anywhere from 1 to 10 units per kg per hour. Where do you pick? It's arbitrary. I could not find any evidence anywhere really to suggest where to start. So I just start in the middle and then kind of titrate up or down based on what we're getting. But honestly, I'm a lot quicker to go up on the insulin rate so that I can reduce how much I'm giving them of the epi and the pressors and whatnot. So you're going to pick a number, a random number. If your hospital has a policy, go with that. Most hospitals don't have a policy because this is a rare thing that you don't see often. And you may even have to be the person who institutes the guidelines for it because it's that rare. Hold on for 1 second. Let me do this one. So you started the insulin. You now have a systolic that's reasonable. You've got a systolic of like almost 100. What do you do now? Well, this is where it gets really confusing. This is why you have to have a whole nurse just to freaking sit there and push buttons on the pump because you're titrating so much. And it happens pretty quickly. It's usually a day to 3 days. I've seen it happen like within 24 hours. That's what I've typically seen. So that's anecdotally what I think happens. But so it's quick. And they need a lot of instruction because they don't know what to do because it's so, again, rare. They're not used to it and it's a lot of stuff. So I will usually just tell them, I want you to max out the insulin. And as you're going up on your insulin, start reducing whichever pressor it is you want to reduce first based on what your issue is. For me, I want to get them probably off the Neo first. And then based on which drug it is, I would pick either the Epi or Levo. Vaso would probably be last to go because, Vaso. But so they're going to start coming down on that. They're going to go up on the insulin drip. And then eventually they'll be off the pressors and the insulin drip will start to come down. Magic. It's magic, friends. It's absolute magic, but it works. So that's the insulin. The other thing that you can consider, I've done one time, is a lipid emulsion. So, when we're giving people TPN and you have the TPN bag and you also have the little white bag of fat, that's what I'm talking about. You can use this. What this does is it sequesters lipophilic drugs, verapamil and diltiazem. It reduces the volume of distribution, so it kind of it just clumps it together so it's not as harmful. It also provides fatty acid energy sources to the cardiac cells, so the heart muscles get additional support. It's used for that non-dihydropyridine class because, again, verapamil, diltiazem. The problem with this thing is that it requires a lot, and I didn't even write down the doses. I'm sorry I didn't do that. I can't remember off the top of my head. It's a lot. You end up using the whole hospital's supply of lipids to do it. So we don't tend to default to adding that. The next thing you can do is glucagon. Now, glucagon, some of you may have seen used before. It's a little more common thing. Glucagon is the antidote for beta blockers. So it's really ideal in a beta blocker overdose, but you can use it in a calcium channel blocker overdose as well. It's just not probably going to be quite as effective. The reason it works better in beta blocker overdoses has to do with the pathway of the beta receptor is what's blocked in beta blocker overdose. And if you look at a schematic of a cell wall, the beta blocker receptor is bound, so you have to get in another way. So giving glucagon will help open up that receptor. And it bypasses that. The problem with glucagon is that it has a nasty side effect of vomiting. And when I've seen it given, I've seen it instantaneous. You push glucagon, they vomit. I've heard people say it can make projectile vomiting happen. So it's violent response. So somebody who took beta blockers, who's got more of that sleepy effect that we were talking about, who's maybe getting a lot of volume, maybe not breathing so great, you're really worried about aspiration. So do you or don't you, We have given it a couple times on people, those patients where they came in, they carry a diagnosis of hypertension or something, they're on a beta blocker. You continue their home medications, including a beta blocker, and then they get septic while they're in the hospital and their blood pressure drops, but you already gave them the beta blocker that morning. So you got, depending on if it's extended release or not, you may have 12 hours of shock. You could consider giving glucagon to reverse that. And we have done that before. I have seen it work. So there's an indication for it. Last ditch, ECMO. The lady who died, we asked about ECMO and it didn't happen, but ECMO or move to an ECMO center. Hit them with Lasix. Yes. You give them a lot of Lasix to make them pee it out. Absolutely. And hope that the kidneys have not had taken a hit with the reduced perfusion, but generally they have. So sometimes the kidneys go. I've seen some have to go on dialysis before. But usually the thing about it is this is such a fast thing. This is not like our people who have indolent sepsis that gets worse and then you've got a week of really sick. This is over a 24-hour to 48-hour period is what I've seen. It's really, really fast unless they don't get better, in which case it's a little longer. So you may not have as much time for that problem to occur. And tube them. Yeah, you can always tube them. You can always tube them. But you kind of hate to do that on people who are awake and talking and asking for the remote, you know? So monitoring, well, I kind of already talked about that, didn't I? The volume overload, the multiple staff members. But yeah, so that's really the summary of what you do. And it's scary for the nurses because they're not used to it and the doses are super high and it's so incredibly labor intensive. But it's incredibly rewarding because it's one of these things, once you start the insulin, you see an immediate effect and they immediately start to get better. And these are people who walk out of the hospital. You know, in the ICU, we're used to seeing people like this. They don't typically get better. Or if they do, they're going to be in rehab for a long, long time. long time. So it's kind of one of those like drastic turnaround things. Very, very dramatic patients. And that is all, my friends. That's all I have to tell you on calcium channel blockers. If you ever have one, send me a text and let me know because they will live in your memory forever. And you're like, oh my God, I remember Brianna talking about this. When I sent this blog out earlier this week, I got 2 texts from friends immediately. One of them said, oh my gosh, bro, I have a calcium channel blocker this week. I didn't know what to do. Like, yeah, they're freaky people. But they're kind of fun. They're kind of fun. Sorry. I'm trying to keep this from not getting bad. What else? That's kind of all I got this week, y'all. This took a lot less time than I thought it would. I guess because my synapses are firing better today. Anybody got any questions they want to address? Opinions? Feedback for the good of the group? Am I turning into a teacher? I kind of feel like maybe I am. Oh, I got a question for y'all. Maybe somebody brilliant out there knows the answer. I am working on a lab course. And so I was doing some research on like a metabolic panel. Riddle me this, y'all. Why do we not get a magnesium on any of the metabolic panels? It don't matter which one you order. None of them include a magnesium level. You have to order it separately. Nobody can answer that. I've called 3 different lab managers. They don't know. I figure it must be something with the way that it's like processed. I don't know. I've searched the web. The interwebs doesn't know. Scott said, weirdest overdose I had, I think, was isoniazid. Oh, what? There's like very few people in the world who are on that. That's TB, right? What? That is the other thing. And I really should have put this in the blog. Why didn't I think about it? But that is, you always have poison control. You can always call poison control and they will walk you through this. You certainly could do this. I just, I have a deep-seated need to know how to do things myself. So that's kind of why I research this. And also, the second patient I ever treated with this at my organization, we had to actually write a guideline for it because there was nothing currently there. So I did do a lot of research on it then because it's interesting. We're getting a lot of run-of-the-mill overdoses lately, like a lot of them, a lot of fentanyl overdoses around here right now. I feel like fentanyl is always in style for overdose, but it feels like more than usual these days. And some of it is like, just random people who maybe aren't necessarily drug addicts, but just got their hands on some bad stuff that people put fentanyl in, and it just ended up being too much. It's very sad. Magnesium is mostly found in the bones instead of the blood. I think so. I think that's true. Yeah. I think phosphorus is stored mostly in the bones, right? Magnesium? I don't think so. I could be wrong though. I don't know. Sorry, this friend keeps texting me. Oh, does that have to do with why? Oh, you're answering my question. Sorry, Alex. Yeah, but even still, that wouldn't have anything to do because it doesn't matter either way. You're running a venous sample, but maybe that has to do with the way it's processed. I don't know. It's a good thought. It's a very good thought. I don't know. Hello.
You live?
Yeah.
Oh, I'm gonna go. Her Kenny asked if I would go out to deal with him tonight.
Okay.
Texas Warehouse. Okay, if I go.
Yeah. Bye. Have fun. Teens who have their own cars, you just never see them. They're gone all the time. They have little social lives, and it doesn't involve you. It's very tragic. Very, very tragic. Okay, y'all, I think I manifested my own destiny. Do you remember, was it when was it we talked about board review? It's been a couple weeks, but remember when I told y'all the like humiliating story of how I took boards and how bad it was, and that my kids had lice and I was super paranoid and somebody was watching me and I was like scratching my head the whole time? Guess whose kid got lice again this week? Okay. Yeah. Thank you, universe. We also, I don't think I've ever shared a picture of my family. I should. Every single person in my family, including my husband, has long, thick hair. So guess who's been coming through hair lately? Yeah, super fun. Knock on wood. Only the little one has it. She's the one who brought it in. Thank God. Do you know that somebody around you has lice and you like start itching? Like, oh God, I can feel them in there. The anxiety is driving me. That's the anxiety I have when I took boards. Like, less than 1% in the serum, dude. Interesting. Maybe that does have something to do with it. I don't think I knew that, y'all. This is why I keep y'all around. You teach me things. I don't know what else is going on. Not much really. That's about it. Next week, I think. I don't know. I started writing on something, but I don't remember what it was. Sorry. It'll be something professional because I try and balance it out. One clinical week and one professional week. You'd be my Google jockey. I love it. In the background, please fact check me so I don't tell these people the wrong thing. How bad would that be if I'm on here telling y'all the total wrong thing? It happens. Don't believe everything everybody tells you. Use it as a jumping off point. Do your own research. Absolutely. How to network in a new city. Ooh, that's a good one. Are you thinking about relocating? I was actually talking to somebody just the other day a client who was doing a mock interview. One of my favorite resources, at least as far as job acquisition goes for NPs, is to get on forums. Like there is a Facebook forum for every single subject in the world. I'm sure y'all are already aware. I'm probably not telling you anything you don't already know, but you can find NP specific stuff like Googling Atlanta NPs in GI or Atlanta NPs. And I mean, there's a Facebook group for it. Go find those friends. Everybody's doing everything virtually these days. Search the forum with whatever it is you're looking for, and then find somebody, like I was telling her, like go on this forum in your area. She was looking for a specific specialty. It was GI. So that's why I said that. But anyways, it's hard to find GI APPs because, like any other specialty, right, when there's not a ton of people who do it, and she's trying to network. Anyways, I told her, go on there, search it for GI, type in GI and see what comes up, and see if you can identify any APPs or NPs that are already in the GI field, and literally just DM them. You'd be amazed at what people will respond to when you just reach out with a simple, hey, I'm new in the city. I'm looking for a job. Can you help me? I'm trying to figure out if I want to do this specialty. I was talking to somebody about shadowing, doing this. Like, hey, people love to talk about themselves and love to share their expertise. So all you gotta do is go to them and say, hey, listen, I'm in your area. I'd love to see what it is you do. Would you mind if I shadow you for a couple hours? Most people are going to say yes. Or do you know any contacts? Like, just reach out to people. People overwhelmingly are willing to help, I have found. So that is one of my favorite resources, at least as far as like professional, like job acquisitions. As far as finding friends, I don't know, because I suck at that. I'm probably more introverted than extroverted, believe it or not. So, yeah, but it was something that wasn't the topic, but it was something else. But it's a good thought. Maybe I will put that on the list to do Tinder. That's a different kind of introduction. I would do terribly if I had to online dating. All of you out there who are single, who are in that world, I will give you a moment of silence for how bad things must be, because I cannot imagine online dating. It's bad enough dating in person, but online, like all the nuances. Like one of my husband's friends got divorced a few years back, and I remember him coming over to the house, and we were in our mid upper 30s at the time. And he's like, you go on these sites, on these online things, it's all young kids. So he's like, I'm, wanting to go out on a date with this girl who was 26 years old, 10 years younger than me, and she sends me a text that's nothing but emoji. Like, what does this mean? Happy, sad, cranky, angry? What? I don't know. I don't know. I don't know. It's a struggle. It's a struggle. All the nuances. So, all right, that's all I got, friends. We're about in an hour. I did not go over an hour today. I'm super impressed with myself. I thought it would be with this stuff. But if y'all ever have requests for what you want to talk about, I will add networking in new cities, although I don't know that I'm the expert to do that. But I will certainly put it on the agenda, Scott, and I will consult a friend who's better at that than me. I will see y'all next week. I hope everyone has a good night at work if you're going in. If not, enjoy your beautiful weather today. Thanks for coming, everybody. I really appreciate when y'all all show up and give me such great feedback and hold me to task and act as Google VAs. Love y'all. Bye.